Going?
Sound test.
Yeah, can everyone out there hear me? Someone in the chat respond. Perfect.
Dreams. People that watch it online, they can't hear us. So you do a bunch of interactions as they're looking for.
Okay. Mac, can you patch that off? Okay. For those of you who don't know me, my name's Gabe. Worked for Fort Wayne Fire. Previous to that, worked for Pocatello for a while. Been a medic for a few years now and teaching you guys pharmacology. So this chapter is super dry. Did everyone get a chance to read it? No? Awesome. Perfect.
I'm going to take off, so I'm going to interrupt Gabe real quick. Does anybody else have any paperwork or anything to turn in for the clinicals? Thanks, Gabe.
Okay. There is an attendance form going around. If you're not in the class, go ahead and, I don't know, send it in the chat. We'll get you down. So pharmacology, we're talking about drugs, basically. Drugs, their interactions, how they affect the body. So we're going to talk about safety, the medications that we use, the legislation behind it, and just kind of how they're named, classified, how we store them. Have you guys all seen the Pyxis and worked with the NARC box and all that? Okay. Yeah, we're just going to talk about how drugs affect the body, how they work through the body, how we excrete them, all that. Toxicity, you guys have a whole chapter on that in a couple months, so we're not going to get too in the weeds on that. So you guys can administer certain medications. Beyond what you can do as an EMTB, we're really only talking about oxygen, oral glucose, glucagon, D5 through D50, IV fluids, and then your epi, albuterol, and you guys can actually nebulize albuterol. You won't be able to do duonebs because duonebs include Atrovent, and that's not an AMT skill. So drug profiles. A lot of places to find drug profiles. I brought in my little kit here. So look it up. Please don't take down my wife's information. So a few drugs on there on the list. Some of them are going to be generic. Some of them are going to be brand names. The best place to find information about it, we all have a cell phone. Just look it up. If you don't know what it is,
what's Valtrex?
Oh, yeah. It's not a flare-up month. So dose, you can see there, the Zofran right there. It's the dose 2 or 4 milligrams? 4. So dose is the amount of medication that's being given with the drug. The other thing that's important to note on that, especially with our IV medications, is the concentration. So like you talk about D5 versus D50, same drug, different concentrations. Then action is its intended effect on the body, how it's going to work, how we're going to get through it. So then we've got other things like unintended effects. Does anyone had an MRI? Okay. Did you get the dye, the contrast?
No.
Okay. So if they give you contrast, like they're looking at your guts, the intended effect is to see what's going on in the GI tract, all that. The unintended effect is that it's going to feel like you piss your pants. And they're going to warn you about it. It's just going to happen. And no matter how much they warn you, it seriously feels like pissing your pants. No bad effect. It's just unintended. An untoward effect would be something that's harmful to the patient if we're given a drug and it's actually negatively affecting them. And then toxicity is pretty self-explanatory. So indications for drugs. So a drug you guys can give right now as basics is aspirin. What's an indication for aspirin? Chest pain. Okay. What's a contraindication for nitro? Perfect. Yeah. So indication, why we give it, contraindication, situations we shouldn't give it in. So medication names and evidently sources. So sources, we get our drugs from a few different places. Heparin actually comes from pig intestine. Vegetables, they were like the initial medications. So belladonna, no, foxglove became digoxin. We just took out the parts we wanted and left the other side. Minerals, sodium bicarb. It's a pretty good example of just a regular mineral. Then synthetic compounds, fentanyl, stuff we made in the lab. So on there, your trade name, and we've got an example here in a bit, but the brand name from the manufacturer, so like Zofran is the trade name. Generic name is going to be your ondansetron. Chemical name is going to give the whole chemical structure, and then the official name by the USP that you can look up later. So here's your example. 9-chloro-1-1-beta-1721-trihox. You can see it. Generic name is beclomethasone dipropionate, and trade name Vancero. So we're going like super specific down to the trade name, and then the official name that you can find in the USP is the beclomethasone dipropionate. So we've got prescription medications. That's what I gave to you guys. So prescription is going to be anything that a doctor has to actually give you. Over the counter, and you guys aren't dumb, Tylenol, stuff like that. Other stuff that you're going to run into with patients is
Essential oils.
Yes.
This for me?
yeah. So patients love, especially now, I don't know what the deal is, but patients love to take their own. I think the internet is really spurring this on. I mean, people are trying to give me essential oils for chest pain on calls, stuff like that. There's all sorts of weird little homeopathic remedies out there. Some of them are going to have that untoward effect, especially mixed with medications, so it's good to take those down. So sources of drug information. At the stations, I know like at Station 2, we've got a great big book. Physicians listed all these medications in it. They have to come out, they have to update it. Ultimately, the best place to get information on medications is going to be the internet. Just take it down, look it up. Everyone's got more computing power in their pocket than we had to send a man to the moon. So, before we get too far off the names, does anyone know the difference between epinephrine and adrenaline? What's that?
Sympathetic.
Nope. It's one's Latin, one's Greek. So, nephro is Greek for kidney, and nowhere for some reason, with English medicine, we like to switch between Greek, Latin, kind of all over the place. Like if you have kidney failure, what's that called? Renal failure. Who do you go see for it? A nephrologist. So we go back and forth, but that's synonymous. Adrenaline, epinephrine. So prior to 1906, medicine was just kind of like made by a doctor, handed out willy-nilly. You get they'd make a tincture for you, hand it out. Tincture that used to be super commonly used was laudanum. My grandpa had it for headaches. Super potent opiate. 1906, dude named Upton Sinclair wrote a book called The Jungle about the meatpacking industry. It got everyone like super fired up, and we came out with the Pure Food and Drug Act that made stuff have to be labeled. If it was poisonous, they had to let you know, and that kind of started the basis of what became the FDA. So after that, food, drug, cosmetic, Just made it to where you had to have some information about the drug if it was going to be harmful to you. 1914, the Harrison Narcotic Act comes out, and because there were narcotics going all over the place, laudanum. I saw a picture of a tincture that was THC, opium, and like one other just super potent opiate. Pretty awesome if you had a headache, but not safe at all. So you had to regulate it, list it, and then they regulated the sale of cocaine, opium, and its derivatives. 1956, Eisenhower's in the White House. E pluribus unum is gone, and we're cracking down on heroin and marijuana. It increased the penalties for the Harrison Narcotic Act. Doctors could get penalized a lot harder. Didn't really come down on the individual, mainly on the doctor. 1970, we just got out of the 60s. Drugs were pretty free-flowing, and now we're trying to regulate and come up with a better system of storing our narcotics. These are all mainly not quite illicit, but these are like the, fentanyl and morphine, stuff like that. So federal legislation, we have to have standardized doses for medications, right? So like 2 to 4 milligrams for Zofran. That's pretty standardized. For it to carry a USP label, which we have here, and which you can look up in the USP, it's got to be 95 to 105% effective. So you have a 10% wiggle room there for the drug to work. Government agencies, your FDA is going to be doing the research to get a drug to the point that it can be prescribed. The average time right now for the FDA to get a drug out to market is 9 years, from initial conception to production. DEA is going to do, they're going to deal with more of the illicit drugs, but they also regulate like us and our storage of narcotics. So that's the reason we have to have the boxes on the buses. It's a DEA regulation. Public Health Service, they are in charge of the antitoxins and antivenoms. So we don't have a lot of it here, but like down in Pokey, there were 2 hospitals that carried antivenom at all time. There were snake hospitals. And then the FTC is the regulation of the distribution. So, like I said, it takes years, 9 years. All new drugs have to go through animal studies, and they have to be tested on 2 types of animals. Usually starts with mice or rats, and I think it goes to monkeys or dogs, and then they can start working on people. And it starts out with small groups, goes to larger groups of 1,000, but they have a 4-step process to get it to where it's actually tested in regular individuals. So yeah, healthy volunteers. Then the phase 2 is like groups of 30 to 500. Then larger group, we're talking to thousands, and then they apply for the FDA approval, and FDA can ultimately say yay or nay. So containers should be guarded against possible theft. A lot of the drugs now, you've got to have the push top to keep kids out, and we have to keep our drugs locked up. So the potency can be affected. Prior to, down in Pokey, I don't know what your guys' old ambulances were. Do you have refrigerators with medications in them? No? A lot of meds were required to be refrigerated, but it doesn't seem like there's any standardized regulation on that. It just kind of, sometimes Sux needs to be, sometimes it doesn't, sometimes albuterol needs to be, sometimes it doesn't. So when we're given a drug, we got to talk about, or we got to think of who we're giving it to, right? We got to take special considerations for certain patients. Pregnant patients, you've got the host and the kid. And there are certain drugs will cross that placental barrier, and some aren't. Zofran's pretty safe, won't cross over, whereas an opiate can. So we need to take into consideration the benefit. If you open your books, go to Table 12.4, it's on page 549. So drug classifications in pregnant women are actually broken down into different categories. Category X is it's going to kill. There's no benefit to giving it to the pregnant woman. Category D is there's evidence that it's going to kill the fetus, but it's going to save the mother. And then, C to A. A is the super safe, and it's just a weight. We don't really deal with that. That's going to be more like your cancer drugs, stuff like that. PEDS, medications, different effects in children. Kids can soak up epi, whereas an adult heart can't. Kids can take it like crazy. However, Zofran can cause some bradycardia in kids that it doesn't cause in adults. It's pretty rare, but it has been seen. Kids aren't cruising on the metabolic ability yet, so they're taking a longer time to process drugs through them. And then in some cases, they're chewing through it faster than we are. Albuterol is one of them that they can kind of blow through. And then old people. Their livers aren't working, their kidneys aren't working, everything's kind of slowing down, and absorption rates are lower. As well as they have a host of comorbidities, right? I mean, there's no old people out there that aren't on less than 4 medications, And with that, so any patient, before we're given a medication, we need to be looking at their medications that they're taking and making sure, if we have a patient that's on a super high Oxycontin prescription, we need to be taking that into consideration if we're going to be giving narcotics. Anything that's working. Thanks, Matt. So, in your scope of practice with the drugs that you can give, you ultimately, if something goes south, something goes haywire, you are responsible for that drug that you give, and you can come after it. If you don't know your medications and you dose something wrong, they can come after you. So it's important, any drug that we know, you've got to know the ins and outs, the contraindications. There's going to be something. I got a buddy that is an anesthesiologist in Boise. He just gave sucks to a kid with no knowledge. The kid has a genetic inability to metabolize sucks. So they go around and bring him up. 2 hours later, he's still paralyzed. So you can't plan for everything, but you need to know your major contraindications, side effects, things like that. Ultimately, with that kid, for whatever reason, the test to figure out whether it was sucks or a stroke was to tase him. And so they tased this kid 6 times. He finally comes out of it, and my buddy's trying to tell the mom, this is standard, don't worry about it, we're just checking this out. Finally comes out of it, and the kid goes, Jesus Christ, you going to hit me with that cattle prod one more time? So, very rare.
Where do we keep our cattle prod?
Yeah, we don't.
It's in the BC bus.
So, drug administration must be safe and therapeutically effective. That's why we have protocols. Our protocols have been vetted out. They've been vetted out, and they're there for a reason. They're to help us out. Our protocols are not going to be exceeding a therapeutic range. And it says always keep the field guide handy. Does anyone have, we all have field guides in our buses, right? With the protocols in them. The other thing, if you keep a copy of the KMS protocols, download it on your phone, or just have the ability to look them up. So classifying drugs, we break it into 3 categories. We break it into the body system that they're going to affect, the class of the agent, and the mechanism of action. So nitro causes vasodilation, and we classify it as a cardiac drug. Class of agent, Morphine is an opiate. Its class is an opiate analgesic. And then mechanism of action would be any drug that we break up into alpha or beta, its effects. Like you've all heard beta blockers. So we break, like metoprolol is a beta blocker rather than a cardiac drug. So the CNS, central nervous system, you guys went over this in your anatomy and physiology? Okay. So CNS is brain and spinal cord. That's your lizard brain. With your peripheral nervous system is everything else. So contains your autonomic nervous system, and that's divided into sympathetic, parasympathetic, fight or flight, rest and relax. So this one, I guarantee you guys are going to see something about alpha and beta on your National Registry test. It's table 12-5, page 551. This is a pretty simple breakdown, but it's the breakdown that's going to be most effective. There are alpha and beta adrenergic receptors in different locations, but take this down. This is going to be, I can almost guarantee it's going to be on your test. So we're all working buses. We're all working under KMS protocols. What beta blockers do we carry that you guys know of? Metoprolol. Cool. Is there anything else that we carry that affects beta in one way or another? If you're looking at your chapter, beta 2 bronchodilation. So we're carrying albuterol, which you guys are going to be able to give. It's called a beta 2 agonist, and we're going to get into that here in a second. But definitely learn this, have this down. Another thing, if you're not getting it, there is a ton of misinformation out there about what an alpha and a beta receptor is. There's guys that really try and oversimplify it. Don't get too into the weeds on that. This is going to be your best source of information on that. So if you kind of break down, do you guys do any medical terminology yet? Like talking about lyses? Okay. So sympathomimic, it's miming. It's trying to mimic the effects of the nervous system. And sympatholytics are trying to inhibit that effect. And then antagonizing versus an antagonist versus an agonist. So an agonist is trying to take that adrenergic receptor and it is trying to make it do what it's intended to do. Antagonist is trying to block it. So like a beta blocker, what's that going to be? Antagonist. Whereas albuterol trying to cause vasodilation, that's going to be a agonist. Beta blockers are just it's a good example when talking about your adrenergic receptors. So we're talking in parasympathetic nervous system now. So if it's like the rock and there's BX gas, we've got a big poisoning. At the end of the rock, he walks out, he hits himself with duodote. So what are we carrying to counteract our anticholinergics? Something like that. Atropine, yeah. So we carry atropine. We have a step dose on it to counteract our Sledgem system. Do you guys know what Sledgem stands for? Salivation, lacrimation, urination.
Yeah. So salivation, sweating, lacrimation, urination, defecation, drooling, diarrhea, gastrointestinal upset and cramps, emesis, muscle twitching, and that's it.
Yeah. So that's going to be I mean, chances of us seeing like VX or sarin gas pretty limited. But down in Worley, they could be doing a pesticide spray over. It's happened before that these guys get hit with pesticide because they spray the wrong field. You got workers down in there, and they're going to be exhibiting these symptoms.
Don't we have a pesticide plant? No, we have fertilizer plant. Accusation too. Is that what it is?
What? It's a fertilizer plant.
Fertilizer plant. Okay.
It can blow up.
Sure.
Yeah.
I say diesel.
So parasympathetics, antagonist to parasympathetic nervous system. So it's countering the effects of the parasympathetic nervous system. So that's your anticholinergic, and atropine is the one that's most commonly used. So we're going to get into kind of our classifications of medicines now. Talking through what they are. I'm going to try and give an example and ask, if you guys know a medication in this class that we carry on the buses. So first things we're talking about are analgesics and their antagonists. So what is an analgesic? Pain, yeah. So analgesics, especially an opioid analgesic, binds to the mu receptors and actually block the ability to feel pain. So if we have the mu receptors stimulated with an opioid, what's something we carry to counteract that? That will bind to those mu receptors and not allow that opioid in. Narcan. Right. Naloxone. So what is that going to be? Is that an opioid antagonist or agonist? Antagonist. So our opioids, they're probably your most common form of heavy analgesic. We've got other ones, Tylenol, aspirin. Those are smaller, low-dose, over-the-counter analgesics. When we're dealing with major opioids, those are going to be like your morphine, your hydrocodone, stuff like that. So, and then, so non-opioids, we've got our NSAIDs, which are your ibuprofen, your acetaminophen, which is Tylenol, and then your aspirin. So our opioid antagonist, Narcan. There's also, you guys will run into them, there's one right now, it's called buprenorphine. I can never pronounce it. So it's a low-dose opioid agonist with an opioid antagonist in there. That's this combination. So that you're going to run into someone who is coming off of or trying to come down and get off of their addiction to opiates. It's going to give them that little bit of kind of mental kick, but it's not going to let them get high. So methadone's not the same. You can still overdose on methadone, but it's that same kind of, you'll run into the same thing where guys are trying to taper down, trying to get off of it. But the talking to patients that have taken that stuff, the buprenorphine, it sucks for them. So you can see a lot of times where they won't take it and they'll relapse. Problem with opioids, and we're going to talk about this later, but tolerance is built up with certain drugs. Opioids are one of them. A lot of the opiate overdoses that we see are people who have been using the opiates for a long time. Then they either go to jail, they go to rehab, they come out, they're doing good, and they go right back into the same dose. So when you go back into the same dose with a decreased tolerance, the dose that got you high previously is going to put you into respiratory arrest this time. So if we're working a code, you guys are going to be able to push Narcan, right? If we have someone who's in cardiac arrest, secondary to an opiate overdose, is Narcan going to do anything for him?
Yeah.
What would it do?
It's blocking the receptors, right?
Right.
So it'll stop the reaction.
Problem is they're already in cardiac arrest. So the opiate is going to cause the respiratory arrest, which will lead to the cardiac arrest. So when they're already dead, for the most part, we're going to tube them, breathe for them. The Narcan isn't going to reverse anything once they are already in cardiac arrest. So we can, if we get to them when they're still in respiratory arrest, yeah, we can block those opiate receptors and get them breathing again. How about anti-anxiety, sedative, hypnotic drugs? What do we carry there? Morphine. It can have some effect. Our big ones that we carry, Versed. Ketamine is kind of, you can do some anxiolysis with that, but it's more disassociating them from reality. A lot of times they help patients sleep. Sometimes you'll see it where low dose sleeping, like an alprazolam. But a lot of times it's just for anxiety, getting someone through the day. And you can overdose on it. We don't carry anything that's going to counteract that. So we're going to just bag them through it. Some benzos that you'll probably see, these are your like AM drugs, right? Your LAM, your PAM, diazepam, alprazolam, midazolam. You're going to see that in a lot of times just in a prescription. Sorry, guys. And then anticonvulsants. So anticonvulsants are a lot of times the same kind of class. With the sedative and the anti-anxiety drugs, you're going to see sometimes barbiturates. Big one that you're going to see, the only one that I really see out there is phenobarbital. But they've kind of fallen out of favor for more of the benzo control. So with that, anticonvulsants, you guys, I don't know about county, I know we do. Do you guys have any chronic seizure kids that season all the time and the parents have like intranasal benzos? Okay. Yeah. So we've got a little 12-year-old that like her parents can slam her. I don't think they have to call us until they give like 20 of Versed or something. It's some ridiculous number. But you're going to see a lot of those benzos in these patients specifically. Stimulants. Pretty much everyone here, I'm sure, has had some form of stimulant today. Coffee. Yeah, exactly. What class or what group of patients are we seeing like stimulant overdose in? Who's being prescribed stimulants the most?
Kids?
Yeah, ADHD kids. We're seeing a lot of Ritalin, a lot of Adderall, and then we're all in caffeine, pretty much everyone. The other stimulants you're going to see is you're going to see meth. That's obviously just standard. Obviously, that's not prescribed. Another stimulant that actually we don't carry, but the hospital can use. Sometimes hospitals will actually carry Coke for doing cauterization inside the nose on nosebleeds. Works pretty good. They try and use silver nitrate, but you can actually numb the inside, but I really don't see us ever getting to that point. So they increase the release of dopamine and norepi, makes you awake, aware, but you get too much of it or you get into the methamphetamine realm, you start getting your paranoia, you start seeing your shadow people and all that. Nervousness, irritability, tremors, headache. What is the big, it was probably the buzzword like 5 years ago. The cops always talk about it every time there's a drug overdose, but with methamphetamine, excited delirium. So excited delirium is when a super stimulant overdose, you're completely overloaded, and that patient is a super serious patient that we need to keep an eye on, get a 4-lead on immediately. With our excited delirium patients, what's a super important vital sign that we need to get? Body temp. Yeah, 4-lead body temp. These guys need to have, they're going to come in as a fight. They're probably going to be handcuffed, and we need to just plan for them to code. How long are we on here? 35 minutes? 40 minutes? Let's take a little break. Yeah. Yeah. All right, now there's sound. Sorry, church. So psychotherapeutic drugs there's a lot. And a lot of them, especially on like your schizophrenics, seems like they're always trying some kind of new drug. And anytime I go on like a schizophrenic, someone who's manic, anything like that, take down all their medications, even if I know ESO oftentimes doesn't hardly have any of the medications listed in there, just type them out. It's important, or bring them with. So blocking the dopamine receptors in the brain, that's the doc the other day that gave the talk on ketamine. He brought up the only two things that make you happy are dopamine and serotonin. So treating schizophrenia, depression, lots of side effects. One of them, and kind of the chief side effect that everyone complains about, is lack of sexual activity. When my uncle was initially being treated for schizophrenia, he was like a zombie. There was no, until they were titrating his medications out, he had no personality, nothing. He was just there. So selective serotonin reuptake inhibitors, those are going to be your Paxil, Zoloft, Prozac. Your monoamine oxidase inhibitors, MAOIs. I don't see these as much. Do you see them out in the field super often? No. Marplan, Parnate, and Nardil. Those are like three of the big ones. And then your tricyclic antidepressants. So every medication has a window, a therapeutic index, right, where it works. TCAs are very narrow. They're not prescribed much anymore because they're really easy to overdose on, and giving a depressed person something that's super easy to kill themselves with, we're kind of not in favor of that anymore. But your tricyclic antidepressants, the chief one is amitriptyline. So medic school, they taught us be wary of anything that ends in INE. And that one, they're going to code super fast. Again, it's good to get them on a 4-lead, and you're going to watch a waveform, a sine wave that turns into asystole. So then,
Hang on a sec, Gabe. I'll do the guys do a structure up now.
hanging on.
You're good.
We're good?
You're good.
Okay. So effects on the heart. positive or negative. Kind of like agonist, antagonist. There's three main ways to affect the heart: chronotropic, inotropic, and dromotropic. So chrono, if we break that down, it's time. So that's your rate. Inotropic is going to be your force of contraction. I don't have any good limerick or anything to remember that. And then dromotropic is the velocity of the conduction. So getting from top through the ventricles. So that's all electrical. Talk about cardiac glycosides. So earlier I mentioned belladonna was used, or foxglove, pardon me. So foxglove was used before we had the ability to extract what we actually needed out of it. That's digoxin. Digoxin's another one with a fairly narrow therapeutic index, but you will see it on your AFib patients sometimes. It's kind of getting phased out. Okay, so we're getting into cardiovascular stuff. So this is a word I really don't like: antiarrhythmic medications. So there's only one true arrhythmia, and that arrhythmia is asystole. Everything else is a dysrhythmia. Does that make sense? So arrhythmia is the lack of a rhythm. Dysrhythmia is a rhythm that's not normal. So we don't really have a medication to treat asystole. That's CPR and epi. So these are going to be anti-dysrhythmic medications. So we have medications that you guys learned about: the sodium-potassium pump. That's how muscle works. Okay. So we have sodium channel blockers. Sodium channel blockers, they block the sodium channel. Help slow the heart rate. That's going to be your quinidine, procainamide, and lidocaine. Beta blockers we've talked about. So beta blockers, like we said, we carry metoprolol. Another one you're going to see is atenolol. A lot of these beta blockers end in that lol. That's kind of their base. And then potassium channel blockers, one we carry. It's a potassium channel blocker, sometimes also classified as a sodium channel blocker, but amiodarone. And then here to contradict what I just said about beta blockers, another potassium channel blocker is sotalol. So sodium channel blockers, we're slowing the conduction through the heart. It's a negative dromotropic effect. So dromo is the conduction, not the actual rate. Beta blocker, we're just reducing that stimulation. Potassium channel blockers, it's a positive inotrope. So inotrope is the strength of conduction. It's increasing the squeeze. Calcium channel blockers, that's going to be your diltiazem, which we don't carry, verapamil, amlodipine, and those decrease the conduction velocity. So they're a negative dromotrope. Okay. So antihypertensives. We run into a lot of people. Your CHFers are going to be on this. I'm probably at some point in my life going to wind up on lisinopril based on family history. It seems like everyone's on some form of these. So we have diuretics, which can be kind of broken down into two main groups. You've got your loop diuretic and then your thiazides. So a loop diuretic that we used to carry is Lasix or furosemide. Lots of people are on that. It's going to be in usually like a 20 to 80 milligram range per day. That's what people are generally referring to when they say a water pill. Your thiazides, hydrochlorothiazide. That's the one you see all the time, HCTZ, out in the field. And that's just trying to regulate hypertension through excretion of fluid. Vasodilators. What's a vasodilator that we carry? Nitro. Yep. So some form of nitrate to expand the vascular space. So one that we see, in the field, a long-acting, a lot of times, like first thing in the morning, you see a syncopal episode, guy was moving the garbage out to his street, something like that. Isosorbide mononitrate is a long-acting nitrate that is a vasodilator. You're supposed to wait 30 minutes to get everything going, but guys get impatient, take the garbage out, syncopal episode out in the front yard. So the other ones, ACE inhibitors, that's your angiotensin converting enzyme. I'm sure you guys are all super well versed in the renin-angiotensin aldosterone system. Those are going to be your prils, right? Lisinopril, enalapril, that sort of thing. And I would be surprised if that system is on your national registry test. Anticoagulants, fibrinolytics, and blood stuff. So, what do we carry that has an effect on the blood itself? Aspirin, right? We're giving it within the first 5 minutes every chest pain. That's not allergic to aspirin. So aspirin is actually an antiplatelet aggregate. So it's not going to break up a clot. It's going to prevent the platelets from binding to that current clot. So it's going to prevent it from getting worse, that platelet aggregation. Whereas like an anticoagulant, anticoagulant, we're thinning out the blood. What patients are we seeing taking anticoagulants? Post-surgery. What's that? Okay. So what's causing the AFib? Yeah. So AFib, we'll see a lot of warfarin, Coumadin, same. So that's trying to thin the blood so that they're not building up clots in their atria to send up into their brain. So then fibrinolytic agents, so lyses, this is actually breaking the clot down. So agents like that, that's going to be your TPA. That's why we got to get a stroke alert going quickly. Call the stroke from the house. Kootenai's not super big on TPA, but kind of coming around. Your other antiplatelet agents that people are going to be taking at home. Lots of people taking 81 milligram baby aspirin in the morning, but you're going to see some Plavix at home. And then a lot of times when we bring in a STEMI, they'll get some Plavix before going up to the cath lab. Old timey, if we all had the big long beak mask, Renaissance era, leeches actually have an anticoagulant property in their bite. And I've actually heard of leeches being used like in the last 10, 20 years. So that can still be something, but we're not going to say it. So TPA is the tissue plasminogen activator. And that's what we're trying to get to with our stroke alerts. So drugs affecting the respiratory system. So I know when I was going through EMT school, it was like everybody got oxygen. And you always throw someone on a nasal cannula. Now we've got SpO2. We can monitor that. We're trying to... Is there a reason to put someone on oxygen that's sat in at 98%? Probably not. CO. And our new X series can determine, right? Do you happen to know the affinity rate of carbon monoxide to hemoglobin over oxygen?
It's like 300 times.
I think 162, if I remember right. Yeah. But, yeah, you're right. So before we had the ability to determine, you could see 100% SpO2, and they could have zero oxygen. Well, not zero, but yeah. All their hemoglobin could be bound with carbon monoxide. So getting into respiratory drugs. So a lot of respiratory drugs that we're going to run into in the field are going to be over the counter. You're going to see a lot of like antihistamines. So diphenhydramine, which we also carry. I can't think of the generic name right now for diphenhydramine. Allergy medicine. Pink. No? Benadryl. Thank you. Yeah. Super simple. Yeah, so you're going to see a lot of Benadryl, especially around the springtime. People are taking. One that I see, has anyone been on a Robitussin overdose? Robotripping? No? Okay. So dextromethorphan is Robitussin, and it gets you high. And their overdoses are really weird. They get really super slow speech pathology. It's interesting. But yeah, so robotripping, you can see that. Pseudoephedrine, now they're kind of trying to regulate so people aren't making meth, but you're going to run into that. That's a decongestant. But these people are getting sick. They're having stuff affect their respiratory drive. They're going out to Walgreens and getting everything they can. You're going to run into that wide range of medications that they're taking. For us, what's our big one for respiratory that we're going to be given, that you guys are going to be given? Albuterol. Yep. So albuterol, trying to dilate the bronchi, get more air moving. Lots of people are on albuterol on their own, either through a rescue inhaler or their own neb. So what is a contraindication for albuterol? High heart rate. So when we're administering albuterol, it is a contraindication, yeah? But we need to be thinking about what's causing their high heart rate, right? Are they febrile? Are they running through an infection? Or are they tachycardic because they're hypoxic? So it is a contraindication. It's kind of a relative contraindication, if that makes sense. If you can fix their hypoxia, I'm not telling you guys to break protocol here, but if you can fix their hypoxia, you're probably going to help out on that heart rate. I've had people go from 130 down to 90 through the use of albuterol, opening them up. So yeah, beta-2 agonists. You're also going to see some corticosteroids in the field. A lot of COPDers, they get club fingers from the use of steroids. So you can walk in, you can see big old knobby fingers. One that sometimes it'll be used in the ER, sometimes it's used in ambulance services and EMS systems, is Solumedrol, which is a respiratory steroid. And then xanthines.
When you guys are thinking about steroids too, you guys are going to start IVs and stuff. The IV starts being difficult if they have long use of steroids. So when you puncture the vein and stuff, it's not going to be that nice fluid.
Yeah.
You get that backfill, it's got to be more of a tear. So you'll see more bruising and the skin break down. So it's something to think about when you guys notice that.
Yeah, and pretty much every one of your COPDers is going to be using some form of steroid, either inhaled or oral.
More difficult, or is the tactile feedback just a little different?
It's different. It's a different feel because when you start versus like if I start IV on you feel the puncture, you feel the pop, you got nice great veins. Now you're moving into an 80-year-old lady that's been a COPDer and she's on tons of steroids, and you go in there and it's like trying to start IV through paper, and it's just it's a different feel. You don't feel the pop. Next thing you know, you feel the insertion. You're like, oh, I'm not in. You go a little bit more, and now you're filling that space with blood and stuff. And I'm just saying, you don't have a great puncture. You just have a tear. It tears the vein.
Paper is the best way of putting it. It's just, you guys will feel it once you start doing IV sticks. But yeah, a normal healthy person, you can feel it. There's a pop getting into the vein, but yeah, like he's saying, they're just kind of loose veins. There's nothing really there, and it just it's easy to infiltrate. That's people on steroids for all of you out there. So, drugs affecting the pancreas. What's the big one that we run into? I mean, what's like numero uno? Insulin. Yep. So diabetics, two types, well, not two types, but two kind of major classifications of insulin, right? We've got our short acting and our long acting. So if you go on, we've all been on the person who's low. They're low because maybe their sliding scale's off, this, that, and the other thing. one thing you want to be sure of when you're assessing these patients, did they give themselves 20 units of Lantus on accident instead of their short-acting? Because if you bring their sugar up and leave, they're just going to crash again. So I'm pretty conservative when it comes to long-acting insulin. Some guys will leave them home. I'm pretty conservative on a Lantus overdose, transport them. But you're going to see Lantus, Humalog, Novolog. On your patient who's unresponsive, you don't know why. I mean, obviously you get a sugar, but you can check the fridge because a lot of time that's where they keep it. And then oral, they're going to take maybe a metformin, something like that. So, sulfonylureas, which are not sulfa drugs. Those are sulfonamides. I don't see those very often. You're mainly working with insulin and metformin. And then drugs, immunologic. These are going to be another kind of like psychiatric medications. There is a whole host of immunologic drugs.
Regular question.
Yep.
So think about this, guys. When you guys think of insulin, how would you know you have an insulin overdose, like in your patient?
Questions: how we know we have an insulin overdose?
Sorry.
Yeah.
How would you guys know? So you go on these. I've been on a couple of overdose where they were younger kids that decided to take a whole bunch of insulin to kill themselves. It's one of the longest, most painful ways to die. Is you go into basically shutdown, system shutdown. But what you know is Warren's exactly right. You start pushing a D50 and you have no effect because it's not uptaking right. And so when you get on those patients, what do? Right? IVO2 monitor, pretty basic stuff, but this is where it's time. You have to put a lot of fluid to these patients. You have to get rid of that stuff because ultimately it's a long, painful death. Just something to think about when you're on those cases and you're like, how come my magic wonder D50 drug's not working?
Right.
So you really have to, like you said, you have to look at the insulin, make sure how many milligrams, because that's going to be huge in time. We have to get them as soon as possible. So it's a big long deal.
You brought up the example of a kid. Is it more common to see kids do that than?
I've only been on two, and they've been like 14-year-old girls. I don't know what's the deal, but I've only had two in my career that I've caught, and I'm like, holy cow, I can't fix this. What's the deal? And so my only experience is just unfortunate.
Yeah, well, when suicide comes, choices usually vary.
Yeah. Yeah, I mean, they're at that age group. They had access to it. They're like, oh,
Right.
This drug I think does something.
So the discussion for you guys was, how do we know it's a insulin overdose and it's going to be like your D50 is just not working, sugar's staying low. There was a dude that went up Mount Hood last year that did it, formed a rescue, but he tried to insulin overdose on the top of Mount Hood and then called as soon as he pushed it all. So yeah, and he was 40 something. So yeah, I don't know if it's a specific range, like, yeah.
I know it's a sad deal.
Yeah, it sucks.
It's a long gap.
And people think it's not a big deal, but yeah, shitty way to go.
Yeah, it makes me
So your drugs affecting the immunologic system, you're gonna, like your AIDS patients, organ transplant patients, these are gonna be very specific drugs, and they'll usually have someone around that's going to tell you everything about this patient's history and their drugs. Especially like in an organ transplant, they're trying to keep the body, suppress the immune system from attacking that new organ because the body sees a parasite and tries to go after it. So these patients are going to be super susceptible to everything that the immune system prevents. So infection, all that. So just, keep an eye on them, take them in. Again, gather up all the medications, take them in with them. Vitamins and minerals. Most of us, I'm sure, take some form of vitamin in the morning. You're going to have your just your general like multivitamin. And then a lot of times, in patients who take warfarin, because if their warfarin level gets out of whack, they have to go in for a vitamin K injection. Seems like it's always on a Friday afternoon, and their regular doctor's gone home, and they have to go to the ER for a pretty simple procedure. But some people will be injecting vitamins. We had a gal the other day that was injecting herself with intramuscular another vitamin. And then, so it says thiamine is important in the pre-hospital setting. When I was going through medical school, there was this huge thing, like you're derelict, old drunk, any alcoholic who had a low sugar, you had to hit him with thiamine, or you were going to give him Wernicke's encephalopathy, and then that was going to lead to Korsakoff psychosis. We don't carry thiamine anymore, so I've never put anyone into Korsakoff psychosis that I know of, but yeah, they wanted to be sure and let you know that thiamine is important. But yeah, so your supplements are going to be to either replace a deficiency or to, as a preventative measure, like vitamin K in your.
I don't even think the hospitals, because they used to do, the banana bags.
Kootenai was doing a banana bag the other day.
Oh, really?
Yeah. So a lot of times your chronic alcoholic will get a banana bag. It's like a $3,000 super expensive bag, and it's yellow, full of thiamine. Fluids and electrolytes. You guys are going to go cover this a lot more in depth next chapter, because that's kind of the meat and potatoes. You guys are going to be doing IV sticks. We got crystalloid solutions. So what fluid do we carry, Kootenai County? We carry two, but normal saline, like isotonic normal saline, pretty benign. We don't carry lactated ringers. We carry D5W. You like pokey, all we had was D5W. We didn't have D50. But in your geriatric patients, maybe like someone with thinner veins, try and maybe go the D5 route rather than slamming them with super corrosive D50. It's going to be easier on them, less painful. And, we're trying to take care of our patients. We're not trying to just slam things home and get out of there. It takes a little bit longer, but if they're maintaining their airway, give them a little D5. I think that's in your guys' scope of practice, so it's pretty easy. Yeah. I was reading in their book, you can also administer D50 rectally, but it said consult your local protocols. So I'm really hoping not to see any of that.
I think that's been removed.
Yeah.
Chief, if that pipe comes up.
Yeah, we'll let that one go.
EMTA only.
Right.
Well, I'm out of here.
Yeah. I don't need
I had
this
a
class.
call probably 10 years ago. I transported this lady, seizure,
Uh-huh.
and she's in there in the back. I'm taking her to Sacred Heart, and she's like, "Is the only way to give seizure medications by rectal?" And I'm like, "No, man." She's like, "Oh, well, that's what my husband always buys."
Oh, perfect. Rectal seizure medication. Different strokes, man. All right, so we're going to go into drug forms right now. This is all pretty basic. You guys are using multiple forms of drugs already. We should be able to blow pretty well right through it. So drugs are manufactured to be to their most effective route, right? So you can have IV Zofran. Someone at home can't give themselves IV Zofran. You've got a dissolvable buccal tab. Solid drugs. It's capsules, tablets, pills, suppositories, like we were talking about with the seizure medication. A lot of times, suppositories, actually doing my ride time in Thurston County over in Olympia, we had Tylenol suppositories for kids having seizures. It's not super uncommon, and a lot of times in skilled nursing facilities, they'll also have that suppository of, it's like an Ativan suppository, and I believe that they can give promethazine suppository as well. So it's not terribly uncommon. Oxygen, yeah, that's a good one.
I don't know if skilled nursing facility can't give oxygen, I don't know how we can expect them to give a rectal drug that's going to fix them.
Oh, okay, yeah.
I think when they're
Easy.
wiping the butt, that's when they smear the butt.
Oh, okay.
Your liquid drugs, solutions, that's the drug all mixed together. That's like pretty much everything we carry. Suspension is going to be that drug held inside a type of oil or something else. Tinctures are what they, like that was back in the old days when you went in and they just mixed up a bunch of really badass drugs and handed them out like candy. You have your THC and opium and whatever else you want. Spirits and elixirs, we're in the Western world. We don't see that a whole lot. Syrups, that's your Robitussin, anything that's a syrup. And then emulsions. I don't see much in the way of emulsions. MDIs, meter dose inhalers. What's the most common drug we see in this? Albuterol, right? All your COPDers are going to have some form of this kicking around. They also have a meter dose inhaler with your corticosteroids. Your Atrovent can come in a meter dose inhaler as well. They're as effective as a nebulizer if you use them correctly. We used to have an actual chamber. I don't know if anyone remembers those that you put on the end of it to help someone with their MDI. So you squirted it into the chamber and then they inhaled it through. Topical medications. What topical medication do we carry?
Nitro.
Nitro paste. So again, nitro, it's just in a different form. Lotions, creams, ointments. Old people seem to have any number of these. Because it'll cover transdermal here later. So transdermal patches. This is a big one for your overdose patient. Always be looking for that fentanyl patch. A lot of times if they're into it, they'll load a couple on. I've had a dude chew them up before. I don't know. It doesn't make sense to me, but whatever. So always be looking for that patch on there, especially in your overdose. It's designed to be absorbed, but it's designed to be absorbed at a certain rate with a certain dose. Obviously, loading up multiples on there is going to alter that. Gels, you guys all have the 15 grams of glucose. We give that pretty frequently if they're maintaining their airway. It's pretty self-explanatory. Gases. Is there still talk about us getting nitrous?
Yes.
Yeah. So we could see this in the future. Oxygen is the one that we are all already using, but we could see.
It's certainly not been approved at a BLS
or
A level by the state. However, that's being looked at by the Physicians Committee of the state. And
Okay.
when it's approved, I see Dr. Chun
Okay.
topping on that. I'm pretty excited about it too.
Cool. So
Yeah, because our book says that nitrous oxide was in the A level
yeah.
nationally.
So we're talking about nitrous oxide, and there's talk at the state level of getting it to the basic and the A level. But yeah, laughing gas. Dentists use it all the time, and they're barely doctors. So the routes of drug administration that we're going to be using. So your enteral drugs are anything that goes along the GI tract. So that's going to be oral or rectal. There's really not too many other ways into that thing. So that's going to be, any drug that goes in the mouth or the anus. Parenteral medications. These are the ones we're all excited about. These are going to be your IV, IM, IO drugs. Actually sublingual, so our nitro is not affecting, it's being absorbed, it's not being taken into the GI tract. And then transcutaneous, transdermal, those are going to be our nitro paste. That's the other one we have. And then intranasal drugs. The intranasal is pretty awesome. You don't have to poke people anymore. On the dude that's excited delirium, freaking out, if we can get some intranasal Versed, rather than having to introduce a sharps in there. Safer for all of us. And then inhalation, it's our nebulizer. So anything that's not affecting the GI tract.
I have a question about the IN. How much like success have you seen with using that? Because I know we have the bad devices and stuff, and I've just heard a lot of controversy over you don't know how much is actually like getting in. You don't know how much medication or how it's working or how to like redose and stuff.
Right. The most experience I have with IN medication is Narcan. Not given by us, given by the cops generally. I prefer on Narcan to give it intramuscular or IV if I can. And you got plenty of time on an overdose if they're bagging well. Just get an IV real quick. But it is, a lot of times we get excited, just like anything, we get in there and we slam it home. And that's not the most effective rate. If you want to like get good at it and try and figure it out, take one of those MAD devices, hook it up to a flush, and just try and get it to the point that it's just atomizing, not putting out those big droplets. Because it's not actually trying to droplet the medication in, we're trying to get it vaporized for them to inhale it. So, I don't know, man. I haven't used it enough to... I prefer IV. I know exactly what IV is going to do. So pharmacokinetics. This is...
Side note,
yeah.
That's why, I'm sorry to
No.
make you repeat everything, Gabe.
Go for it.
That's why we taught the law folks when we did the Narcan rollout to give two. Go ahead up one nostril and give your other injector up the other if you're waiting for us to arrive if we're not there yet.
Yep.
And they doubled the dose. It's 4 milligrams in those little IN injectors that the cops are using. 4 milligrams, and our little ampules were 0.4.
Right.
Significantly more Narcan, and we're letting them do both nostrils with two different.
And I guess with like Narcan, it's kind of, there isn't a lot. I mean, you can't really overdose them.
Right.
No, you can't.
Right.
The only side effect is,
Yeah.
they come out and they can puke. And I've only had the puke once, but it's, you know exactly what's about to happen.
I would speak of Narcan.
Yeah.
I know some people talk about they come out swinging maybe because you took away their high and they're super mad at you. Through my experience, though, it's actually, just my perspective, it's just more of a natural reaction. You come out swinging, but give them 30, 60 seconds before you jump on them and let the cops get in there. Usually they'll come out and say, oh, I'm cool, man, I'm cool. But so just know that sometimes when we come out swinging, it's not that they are actually mad at you. It just seems more like that natural virus.
You'd probably do the same thing, yeah.
But as soon as you give them time to kind of see where they're at, then judge them on do they need to be restrained or this or that. And then a lot of medics too, just to get them through that, might restrain them before they push that Narcan, and then reassess their behavioral status once they're kind of come to.
The other thing with Narcan is our dose range allows us to get them to a point that they're breathing again. We don't have to just slam them with Narcan and bring them out to where they need to talk to us. As long as they're breathing, we're pretty happy. The other thing about Narcan, I know everyone's heard this, but it doesn't bind to the receptors as long as opiates will, depending on when you get to them. So you may have to redose. You just got to monitor them, watch their respiratory drive, and go from there.
Exactly why we don't want refusal sign for post-Narcan.
Right, yeah, no refusals for post-Narcan. That's going to be one that if they do try an AMA, you might have to do a PC hold, something like that, get the cops involved. And the cops should be there if we're on a Narcan overdose anyway. Another thing, speaking of cops and Narcan, every single patient who has any sort of drug on board is going to be receiving Narcan from the cops. It doesn't matter what type. The last 2 excited deliriums I got, the cops handed me their Narcan and their atomized device, and were super stoked they'd gotten it on board, but it hadn't done anything yet. So just be aware of that.
That's a good teachable moment too. I've had one where she pushed, I want to say 13, 14 milligrams or something.
Yeah.
And she was like, it's just not working. I'm like, well,
That's
because it's the wrong drug.
Right.
What? But if you push this, they're supposed to wake up. Well, no, we should manage the airway.
Yeah. And Narcan can be used if you're on the patient that has 18 different medications out there. Narcan can be used as kind of a diagnostic. What did they get on board? It's not going to hurt them. What's that?
Like we're ruling things out.
Yeah. They've got 18 different pain medications. There's heroin, there's whatever, there's just any sort of unknown. It can be used as a diagnostic. So don't be afraid of giving it.
I want to say our old protocol was any unknown altered. You gave an argument. I don't think that's changed, but
They also, especially like younger, mostly males, but I'm sure to younger females as well, but they'll pop everything, all sorts of stuff in mom and dad's cabinet. So
Yep.
I've had it where they were altered, unconscious, but it did help a little bit, but they also took some kind of benzo on board, so they're still out of it, but it just improved. But so keep that in mind, that it's not always just the narcotic, it could also be other things on board.
Yeah, I'm talking about polypharmacy, multiple different types of drugs on board, and you might reverse one but not reverse the other. So pharmacokinetics is our study of how the drugs, the action on the body and how we metabolize them. How they absorb, how they're distributed, and then how they actually move through the system. So sometimes we'll give a drug, this is like above my pay grade, we'll give a drug for its effect as it metabolizes through the system. So like norepinephrine will be given in the hospital, not for the purposes of norepinephrine, but how it's going to continue to work down the line. And then I forget the doctor's name, but he gave the speech on ketamine, Spokane's director, Edminster. So one thing he said that was really good to know how your drugs are eliminated. If you've got a drug that's eliminated through the kidneys and you're on a renal patient, it's probably not, it's going to sit in their system for a lot longer. And then, so we're going to continue to talk pharmacodynamics, how it produces what we're after. Does it bind to a receptor? Does it bind to a receptor and stimulate another chemical to be produced? How it works, basically. And then any factors that alter the intended response, anything that they might also have on board. So the mechanism of action is how the drug works. It's got to reach appropriate concentrations at its site of action. So which drug do we carry that appropriate concentrations at the site of action is super important. You guys have probably squeezed a bag, maybe pushed a flush. Adenosine for SVT. So adenosine has an 8-second half-life, and it's got to be able to hit the heart at that time. So you want to try and get your large bore IV. It's going to be this big coordinated effort of trying to slam it home. So the magnitude of response depends on the dose and the time it takes the drug to travel in the body. That's pretty self-explanatory. 2 milligrams of morphine versus 10 milligrams of morphine is going to be different. Whereas 10 milligrams of morphine taken orally is different than 10 milligrams of morphine IV. And then the chemical change that produces the expected effect. That's your pharmacodynamics. And again, the pharmacology is a doctorate class, and we're here for one chapter. So there is a lot going on here that we're just kind of touching on. Your drug response relationship. So the amount of medication given and the response it causes. We're all pretty clear on high dose, more response, low dose, less response. Know how long it takes your drugs to work, how long they're going to work, and the termination of action. So we want to, if we're going to paralyze someone, and we're using a long-term 45-minute paralytic, we want to know when we sedate that person, how long our sedation is going to last, because I don't know about you, but I don't want to be paralyzed knowing what's going on, laying there and not being sedated. So we really need to know, and the duration of action, that's that long versus short-acting insulin. If we've got something that's going to last all day, and we give them a sandwich and, get them up to 100 and walk out the door like we typically do, they're going to crash as soon as we leave.
So when you think about your drugs and what exactly exactly what he's talking about, the mechanism or how long the drug works. And when you're talking about like a long paralytic, what he was talking about 45 minutes, and you're trying to get your certain sedation and how you feel, this is the most important. Well, understanding one, how the drug works, but two, looking for those changes. So you as EMT advances, what are going to be some things that are going to be a telltale sign about how these drugs, if they're not sedated properly, how would you know? Because he just said they're basically paralyzed, they won't tell you, but this is where vital signs are so important, right? We look at respiratory drive, we look at increased blood pressures, increased tachycardia, right, heart rate. So the different stuff on the monitor you're going to see different changes. You have to be understanding the medication, but you also have to look at your patient and understand that they're having changes that they're not going to tell you, hey, I'm not sedated enough, buddy.
Right.
You know, you have to see how they're bagging, how they're responding, all that stuff. So this part is huge for you guys, especially if you're going to start giving medications. You have to pay attention to your patient because they're not going to tell you anything. So you have to be on the ball. You have to be a monitor, an airway monitor. I tell you,
And that's
can't stress that.
And that's something, I don't know if any of you are going to go to medic school and continue, but even just in the back, if you notice, like, hey, the patient's heart rate just went up 20 beats a minute, that's something that you guys can be stewards of and help remind the medic, this guy's coming out of it, we need to probably put him back down. If he's bucking the tube, that's too late. We've really screwed up. The therapeutic index, that's that ratio that it'll work, right? There's actually a ratio for it. Drug's lethal dose for 50% of the population compared to its effective dose for 50% of the population. That's above our pay grade. That's not my jam. But know the drugs like your tricyclic antidepressants that have that narrow effect that's going to work. Where if we get on the other side of that therapeutic index, it can be super lethal. So factors that influence medication interaction. Like we said, we are the generation, every generation that comes is the most medicated generation we've ever had. So your old people they bring out like a tub of medication, and then they bring out their wife's tub, and you got to take it all into consideration anytime we're giving a medication is what are they on, what have they been taking, how many weird herbal supplements have they been using. I mean, maybe someone's on Dig, but they're also taking foxglove essence. I don't know. Are they a long-time smoker? Are they eating? Have they just eaten and now they've taken their short-term PO medication? It's going to influence it. Are they a chronic alcoholic that's also taking Tylenol every single day and now their liver's shot? Anything which the patient was exposed to, that'd be like, I don't know, your hazardous exposure. Yeah.
The one that I would probably see the most is St. John's wort. You guys familiar with that? What do you take St. John's wort for? Depression, usually, or just kind of mood.
St. John's wort for depression.
Kind of put you in the mood. Well, these older patients, they'll take the St. John's wort and they'll get a new medication, like a blood pressure medication. And what happens is when those two intermingle, it lessens the potency of the blood pressure. So now they're calling you because why? They're having blood pressure issues and that kind of stuff. So, don't rule off that package of herbal stuff. Still have to document that, still bring that stuff, because sometimes some of those remedies counteract the medications that you're supposed to be taking. So, something to think about.
I know it's been an hour since the last break, but we're like 5 slides away. So let's just hammer through it. So factors include influencing, our predictable responses. So St. John's wort and blood pressure medication sounds like that is a predictable response that we can expect and understand. The iatrogenic response. I actually had to write this down because I guess forgotten. But an adverse condition inadvertently induced in a patient by the treatment. So the kid who got the sucks and couldn't metabolize it, that was inadvertently induced. They had no way of knowing it. The kid had never received sucks before, and he just super rare, couldn't metabolize it. Well, it's kind of an unpredictable response.
Is it like another term for something that you basically get like from the hospital, like from the like you said, like from the treatment, iatrogenic, like anemia? So, for instance,
Sure.
because of something they gave you at the hospital that wasn't meant to happen, or
Yeah, sure. Yeah. Yeah, exactly. Anemia as a result of a treatment.
that it was, yeah, it was like almost like an accidental, or I don't know. That's the thing.
Right. It's kind of hard to differentiate between that and the unpredictable response. I mean,
when you think of medications, like lisinopril, right?
Yeah.
You think, oh, it's going to fix my blood pressure. Well, in all honesty, it's doing something to your body. It's changing your chemistry to where in 5-6 years now, your body's going to get used to that, and you're going to now forever be on something else. You'll always be on medications.
Sure.
And that's the tough.
You're going to be prednisone dependent or anything like that. It's altering.
Like, this medication causes this, fix this, but in hindsight, it put you in an anemia, or now it put you into, you got renal failure. Sorry. I think of a lot of drugs that we actually, the scary drug for us is Spokane Fire. They're using that drug after fires, CO2.
That's not cyclobenzaprine.
It's the blood that looks like the blood.
Yeah. Carboxy, yeah.
Yeah.
Yep.
So that medication is so toxic that, yay, we pushed it, we saved their life from a fire, yay, but it puts them into renal failure and devastates them. They become toxic for a month. And ultimately, they will die from it. And we actually do more harm putting that stuff into them just for the quick save. So there's a lot of drugs that ultimately, think of amiodarone, right?
Yeah. 40-day half-life.
Spends 90 days in your system. It's so toxic. There's a dose range. We only get 450 milligrams. That's what we can push. But in total, in a 24-hour period, we can only have 2,200 milligrams or 2.2 grams of this stuff because it's so toxic. But in the hindsight, we're taught what? It's an anti-dysrhythmic.
Anti-dysrhythmic.
Yeah.
So it's going to save them.
The world, right? But in all honesty, we make these patients toxic.
The other thing about pharmacology, this is my little tinfoil hat thing, so the pharmacological industry has 4 lobbyists for every representative in the United States. It is like the biggest money maker. And so one drug comes out, and now amiodarone is influencing ACLS. It replaced lidocaine, which we were using forever. So amiodarone is now the primary. Seattle does a study, and there is 0 difference. It was like 0.1%, which is not enough to be conclusive.
But it was enough to make us go from pre-filled syringes to 2 big
Right. Yeah, no
vials
pre-fills.
that we had to draw up with foam in them. It was horrible.
Yep.
They cost $75 a bottle.
Right. So just keep in mind there's a lot of, not misinformation, but there's a lot of higher powers influencing this stuff. And then unpredictable responses. That's going to be your allergy. If you've never had a drug before, you can't know that you're allergic to it. And that would be an unpredictable response that we can't anticipate.
Have you gone over like a retrograde effect from medication?
No.
So like, he had mentioned like Adderall and like how for
Hey Josh, you might want to get on the mic.
and
And it's a pain if you're out
Yeah.
Sorry, absolutely.
Sorry.
Talking about retrograde.
He just put his head on his shoulder.
Yeah, I'll just. No, just one thing to bring up, like a retrograde effect with medication. It's pretty interesting how people with some kind of hyperactive behavioral syndrome, there's a lot of them out there, but some kind of ADD can take something like Adderall. And if we were to take it, a lot of us, we're sky high, where it's a stimulant, whereas those kind of people, it simmers them down. And I'm sure everyone has had an experience in here when you're like, oh, I need to take that Red Bull or that Monster or that coffee, and you think all of a sudden it's going to jack you up, and then all of a sudden you're ready to fall asleep. And why does it do that to us sometimes? Well, that's like a retrograde effect. You get the opposite effect that you were looking at. So our bodies are weird. They're always trying to, as soon as you put something in your body's trying to compensate. You're going to try to bring down the blood pressure or something, the body's going to jack up the heart rate. So medications can react the same way 100 times, but then the next time it can do something weird or opposite. So just keep that in mind. But yeah, cool.
So yeah, under
Thank you, Gabe.
under the unpredictable responses, we got a couple different forms. There's your idiosyncratic reaction, which is your one-off, unexpected, kid can't metabolize, sucks. It's weird. Then you've got your really unique kind of similar deal. If you were to, the book's description was if you had a seizure in response to nitroglycerin. It's a unique, I don't know why that would be different than idiosyncratic, but it's not going to happen to the majority of the population. Then you got your refractory. Have you guys heard of like asthma that's refractory to albuterol, right? So the drug that's intended to work is not working. The disease process isn't allowing it to work. And then you got your potentiation. So they used to say that like Phenergan and fentanyl potentiated each other. In all reality, you're just giving two sedative drugs, or two drugs with sedative properties. So it's not really a potentiation of pain increase, you're just sedating someone. But alcohol and Tylenol potentiate each other. So reducing medication errors. So this was kind of a new one for me. When I went to school, there were 5 rights. Now there's 10. So the 10 rights of medication administration, it's got the same first 5. You got your right patient. So make sure that it's the correct patient. Right medication. So you're looking at it, you're reading it, you're talking to your partner. The right dose, right route, right time. So that's all the like giving the medication. So anytime you're giving a medication, it's a good process. Turn someone and just say, this guy's having respiratory distress. I'm going to give him albuterol. I'm going to give him the whole fish, nebulized, and it's, I don't know, the right time. The right time is like, he's not in respiratory arrest. He's in respiratory distress. Then the right documentation and reporting, right assessment, right to refuse, right evaluation, and right patient education. Those evidently cropped up in the last 7 years. This is a picture of angioedema in response to an ACE inhibitor. Fairly rare, but we do see it. So the medication error here, I don't think it is a medication error. It's just an adverse reaction. I don't know why they included it here. But use your current reliable medication reference source. That's going to be your protocols, or like I said, pull your phone out. If for some reason you're in the back and you're about to give a medication and you need to look it up on your phone to ensure that it's right, maybe don't give the medication and turn that patient over to someone else. You should know going into this. And then have your partner confirm the volume in a syringe. So our Zofran right now is 4 milligrams in 2 milliliters. Ensure that the volume correlates to the dose that you want to give with that medication's concentration. So evaluate for hypersensitivity. The only way you're going to be able to do that is ask them if they've had this drug first. Do they have any contraindications? So the big one that we all know, EMT basic, is any ED drugs within 48 hours, you're going to have a hypersensitivity when that nitro is given as well. So be sure to do a real thorough evaluation of your patients. Go through, find out their medications, knock all your contraindications off, because you really don't want to be the dude that gives the aspirin and then asks if they're allergic to aspirin, and now you put them over the edge. And Hypersensitivity, a lot of people will say, oh, I can't have aspirin. It's not that they can't fully flesh that out. They might have a doctor who said, don't take aspirin because you're already on warfarin. We want to get that antiplatelet aggregation. And it's not just aspirin. Just fully flesh out, oh, morphine makes me a little itchy. Morphine makes me tingle. Fully check if you're going to give a medication. Do they have a true allergic anaphylactic reaction to it? So there's an Institute for Safe Medication Practices. They have developed a list of medication abbreviations. When I'm charting a medication, I don't like to use an abbreviation at all. There's too much, MS, could be morphine sulfate, could be magnesium. I don't like it. Just write it out when you're charting. We're busy, but we're not busy enough. We can't take the time to do that. Your specific medications, like that's here in the back of the chapter that we talked about. It sounds like Dr. Chun is meeting with the Physicians Council, or the group of physicians that determine state protocol.
Yeah, actually, Dr. Luther is doing
Dr. Luther.
Dr. Luther is now part of that state.
Okay.
He took Dr. Chun's place.
Gotcha.
So Chun's message is coming through Luther.
Okay, got it. So the doctors are working with the state to try and, like we said with nitrous, we're going to continue to work on medications you guys can give. We're going to continue to go forward, but for the sake of learning your national registry stuff, learn everything that's nationally allowed by an EMT advanced. So, because you're going to get tested on all of it in the national registry test. And then when you get your national registry, you can work on your Kootenai County stuff. Also, keep up on your national registry. This is my little pearl of me. iGEMs, I'm not a huge fan of. National registry is a lot easier to document. And then you take your number and you send it to Idaho and they give you your card. So it's a whole workaround that's pretty easy. Costs you like $35 every 2 years. Not a big deal. Okay, do we have any questions? That was a lot. Yep.